All right, let's talk about vital signs, but not as some boring checklist you have to get through. We're going to treat them for what they really are, a language. It's your patient's body talking to you, constantly giving you updates on what's happening inside.
So let me ask you this. Are vital signs just numbers? Is taking a blood pressure just about getting a reading and charting it? Absolutely not. If you think of it that way, you're missing like 90% of the story.
Here's a better way to think about it. Every vital sign is a clue, and your job, as the nurse, is to be the detective. You're the one who has to piece it all together to solve the puzzle before it turns into a full-blown crisis.
Okay, so every good detective needs a code, a set of rules they live by. For us, it all starts with one golden rule. You are responsible for keeping your patient safe.
And that brings us to this really critical point. Can you delegate the task of taking a blood pressure on a stable patient to assistive personnel? Yes, you can. But can you delegate the responsibility for understanding what that number means, for deciding what to do about it? Never. That interpretation, that action, that is always, always yours.
So let's play this out. Your AP comes to you and says, hey, the blood pressure in room 2 is 180/100. What do? You don't just grab the medication. You say thank you, you walk into that room, and you retake it yourself. You have to personally verify any abnormal finding before you act. It's your license on the line, and more importantly, it's your patient's safety.
All right, let's grab our first clue, temperature. We're going to go way beyond just hot or cold and really look at the story a fever tells us about what's happening inside the body.
You see, a fever isn't just one thing. It's more like a 3-act play. Act 1 is the chill. This is where the brain's thermostat gets hijacked by some bug and cranks the body's set point way up. But the body's actual temperature is still low, so the patient feels freezing cold and starts shivering like crazy to generate heat. Act 2 is the plateau, where the body finally catches up to that new high set point. And then Act 3, the flush. This is when the fever breaks. The brain drops the set point back to normal, and suddenly the body is way too hot. So what does it do? It hits the emergency cooling systems. You get tons of sweating and vasodilation, where the blood vessels open up to dump all that extra heat.
Now here are 2 huge takeaways from this. First, shivering is not just some minor discomfort. It is dangerous. It can jack up the body's oxygen demand by 400 or 500%. That puts a massive strain on the heart and lungs. Second, a couple of exam traps. That rectal temp, which is super accurate for core temperature, it is an absolute no-go for patients with neutropenia, low white blood cells, or bleeding risks. The last thing you want to do is introduce bacteria or cause a bleed in those patients.
Let's move on to our next set of clues, the messages coming straight from the heart and lungs. We're talking pulse and respirations. These two are joined at the hip and tell us so much about how well the body's getting oxygenated.
Now, when you're taking a pulse, where you take it is a big deal. For a routine check on a stable patient, sure, the radial pulse on the wrist is your go-to. But the second you're dealing with an irregular rhythm, or the patient's on certain cardiac meds, or you're assessing an infant, you have to switch to the gold standard, the apical pulse, listening right over the heart.
And this right here, this is a non-negotiable. Gotta know it for the exam rule. If you feel that thready, irregular beat at the wrist, you must listen to the apical pulse for 1 full minute. No shortcuts. Why? Because with an irregular rhythm, some of those heartbeats are too weak to even make it to the wrist. If you only count the radial pulse, you'll get a number that's falsely low, and you'll completely miss how fast the heart is actually beating.
Okay, let's talk about what might just be the most underrated vital sign of them all. Your patient's respiratory rate is often the very first clue that they're starting to go downhill. But here's the trick. You can't just tell someone to breathe normally. The second they know you're watching, they'll change how they breathe. So here's the pro move. Pretend you're still taking their radial pulse. Keep your fingers on their wrist, but slide your eyes over to their chest and count their breaths. They'll never know.
And it's not just about the number of breaths, it's about the pattern. You've got to recognize these signatures. Tachypnea is regular but fast. Bradypnea is regular but slow. But then you have these others. Cheyne-Stokes, this eerie pattern of not breathing at all, followed by deep, rapid breaths. That's often a sign that a patient is actively dying. And Kussmaul respirations, that deep, fast, almost frantic breathing, is the body's desperate attempt to blow off acid during diabetic ketoacidosis.
All right, now for the main event, we're diving into the one vital sign where the most common and frankly most dangerous mistakes are made, blood pressure. And believe it or not, it almost always comes down to one simple thing. These two numbers right here, 40% and 80%, This is the absolute law of blood pressure cuff sizing. The width of the cuff's bladder needs to be about 40% of the arm circumference, and the length of that bladder needs to wrap around at least 80% of the arm. Burn this into your brain, everything starts here.
I'm telling you, without a doubt, the #1 error in blood pressure measurement is using the wrong size cuff. It's not about being hard of hearing or having a bad technique. It's about whether you took 2 seconds to grab the right piece of equipment for your specific patient.
And this is why it matters so much. If you use a cuff that's too small, you're going to get a falsely high reading. Think about that. You might get a reading of 160/90 and go give a powerful blood pressure medicine. But what if their real pressure was only 120/70? You could literally bottom out their blood pressure. On the flip side, a cuff that's too big gives a falsely low reading, and you might miss that your patient is dangerously hypertensive. Getting this right is fundamental to patient safety.
So let's apply this to a super important assessment, checking for orthostatic hypotension. Really, what we're doing here is figuring out if our patient is a major fall risk.
Here's the textbook definition you have to know. A patient has orthostatic hypotension if, within 3 minutes of standing up, their systolic pressure, the top number, drops by 20 points or more, or their diastolic pressure, the bottom number, drops by 10 points or more. You'll measure it lying, then sitting, then standing, looking for that drop.
But why do we even care about these numbers? Because this isn't an academic exercise. A positive orthostatic reading means your patient is at a huge risk of getting dizzy and falling the second they try to get out of bed. Your #1 priority immediately becomes fall prevention.
Okay, let's bring it all home. We've gathered all our clues. Now it's time to put it all together into a final, high-yield summary of exactly what you need to remember. Here it is, the cheat sheet. For temp, know those rectal contraindications for bleeding and infection risks. For pulse, if it's irregular, you go apical for 1 full minute, period. For respirations, remember that it's your canary in the coal mine, your earliest warning sign. For SpO2, please treat the patient, not the monitor. If the reading is low but your patient looks fine, check their hands. Are they ice cold? Is the cuff on the same arm inflating? Is there nail polish? Check for all those things that can mess with the reading before you sound the alarm. And finally, blood pressure, cuff size, cuff size, cuff size. Too small equals a false high. Master these and you'll be on your way.
So we'll end on this thought. We've spent all this time learning to decode the secret language of the body. But being a great detective, being a great nurse is about more than just the data. So now that you can read the signs, what are you going to do when your patient starts talking to you? What action will you take? Because that is where the real art of nursing begins.